Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 144 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the next question reads, FPL, a 59-year-old male patient is transferred to your MICU from the general medical ward, with a chief complaint of diffuse abdominal pain. Some of his vitals include a maximum body temperature of 38.8 degrees Celsius, a WBC of 27 × 10⁻³ cells per millimeter cubed, a heart rate of 125 beats per minute, and an MAP of 57 mm of mercury. His abdominal CT shows a large amount of intestinal air, suggestive of ileus and moderate transverse and sigmoid colonic inflammation. He has a past medical history significant for a recently completed 4-week course of broad-spectrum antibiotic therapy for a postoperative osteomyelitis after repair of right comminuted femur fracture, increasing the suggestion of CDI. So my question to you is, which regimen would be the most appropriate for the empiric management of a suspected CDI in FPL's case? Would it be A. vancomycin 250 mg orally or by nasogastric tube 4 times daily, or B. metronidazole 500 mg orally or by nasogastric tube thrice daily and vancomycin 250 mg orally or by nasogastric tube 4 times daily, or C. vancomycin 500 mg orally or by nasogastric tube or feeding tube 4 times daily, metronidazole 500 mg IV thrice daily, and intracolonic vancomycin 500 mg instilled thrice daily, or would it be D. metronidazole 500 mg IV thrice daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. vancomycin 500 mg orally or by nasogastric tube or feeding tube 4 times daily, metronidazole 500 mg IV thrice daily, and intracolonic vancomycin 500 mg instilled thrice daily. This patient is thought to have fulminant CDI according to the IDSA 2017 guidelines, given his recent exposure to broad-spectrum antibiotic therapy, signs and symptoms of infection, CT findings and the presence of hypotension. Combination therapy with metronidazole and enteral vancomycin is indicated. That makes answers A and D incorrect. The presence of ileus requires consideration of adding intracolonic vancomycin because of possible impaired delivery to the colon through enteral routes. That makes answer C correct, and answer B incorrect. Let's move to the next question please. And the next question reads, JOK, a 77-year-old male patient is admitted to your MICU with a chief complaint of severe pneumonia. Broad-spectrum antibiotics are initiated on MICU admission. On day 5 of admission, his culture is negative. He has several liquid bowel movements which require a rectal pouch, that is, approximately 1.6 liters of stool in the past 24 hours, a low-grade fever, a WBC of 27 times 10 power 3 cells per millimeter cubed, a heart rate of 124 beats per minute, an MAP of 67 millimeters of mercury, a serum lactate of 1.6 millimoles per liter, and a serum creatinine of 1.5 milligrams per deciliter. A stool sample is sent for a suspected Clostridioides difficile infection, abbreviated as CDI. So my question to you is, which regimen listed below would be the most appropriate empiric management of a suspected CDI in JOK's case? Would it be A. vancomycin 250 mg orally or by nasogastric tube 4 times daily, or B. metronidazole 500 mg orally or by nasogastric tube thrice daily and vancomycin 250 mg orally or by nasogastric tube 4 times daily, or C. metronidazole 500 mg IV thrice daily, or would it be D. metronidazole 500 mg IV thrice daily and intracolonic vancomycin 500 mg instilled thrice daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. vancomycin 250 mg orally or by nasogastric tube 4 times daily. The patient in this case presents with what is likely an initial episode, severe CDI, as supported by new-onset diarrhea and clinical signs and symptoms of infection. Of note, the patient is not hypotensive and has a lactate below 2 to 4 millimoles per liter, suggesting the absence of shock or other defining features of complicated CDI, thus monotherapy with enteral vancomycin should be initiated. That makes answer A correct. Combination therapy with oral or enteral vancomycin and intravenous metronidazole should be reserved for a complicated CDI. That makes answer B incorrect, and intravenous metronidazole is not recommended. That makes answer C incorrect. The combination of metronidazole and intracolonic vancomycin is recommended for patients with a complicated CDI and there is concern for ileus or inability to deliver oral or enteral vancomycin to the colon. That makes answer D incorrect. Let's move to the next question, please. And the next question reads, N.A.S., a 59-year-old male patient is admitted to the SICU, following a bowel resection following an acute bowel obstruction. On postoperative day 3, N.A.S. has worsening tachycardia and decreased urinary output, with a maximum body temperature of 39.4 degrees Celsius, a WBC of 18.2 times 10 power 3 cells per millimeter cubed, and worsening pain around his surgical wound despite minimal erythema. On opening a few sutures of the wound, pus is expressed on examination, and crepitus is noted in the area surrounding the wound. N.A.S. is emergently taken to the operation room for expiration. He requires significant debridement of necrotic subcutaneous tissue including the involved fascia. The wound is left open with a temporary gauze dressing. So, my question to you is, which of the empiric antimicrobial regimens listed below would be the most appropriate for N.A.S. now? Would it be A. vancomycin, or B. piperacillin, tazobactam, clindamycin, and vancomycin, or C. clindamycin, penicillin G, and vancomycin, or would it be D. ceftaroline and vancomycin? I will give you 10 seconds to choose the correct answer from the options listed above. And the correct answer is B. Piperacillin, tazobactam, clindamycin, and vancomycin. Necrotizing fasciitis is a severe, life-threatening infection that is often polymicrobial. Prompt surgical debridement of necrotic tissue and broad-spectrum antibiotic therapy are the mainstays of initial therapy. Agents active against Streptococcus pyogenes, MRSA, and aerobic and anaerobic gram-negative bacilli should be initiated empirically, together with adjunctive clindamycin added, which may decrease bacterial toxin production. The empiric regimen of piperacillin, tazobactam, vancomycin, and clindamycin is most appropriate, given the severity of infection despite the absence of traditional multidrug-resistant organism risk factors. That makes answer B correct. Penicillin G is not broad enough. That makes answer B incorrect, and the combination of ceftaroline and vancomycin does not contain clindamycin. That makes answer D incorrect. Vancomycin monotherapy does not include gram-negative activity or adjunctive clindamycin. That makes answer A incorrect. Let's move to the next question, please. And the next question reads, the results of the intraoperative tissue culture from the debridement of N.A.S.'s wound show many gram-positive cocci in chains and moderate non-lactose-fermenting gram-negative bacilli. N.A.S. is to undergo serial intraoperative debridements of necrotic tissue. Given the concern for Streptococcus pyogenes, which pharmacotherapeutic intervention would be the most appropriate for definitive treatment of necrotizing fasciitis in N.A.S.'s case scenario? Would it be A. Give intravenous immunoglobulin, IVIG, or B. Ensure vancomycin is part of the regimen for concerns of Streptococcus pyogenes resistance, or C. Give adjunctive clindamycin for toxin production, or would it be D. Add synergistic gentamicin? I will give you 10 seconds to choose the correct answer from the options listed above. And the correct answer is C. Give adjunctive clindamycin for toxin production. The intraoperative cultures of this patient's necrotizing infection are of concern for Streptococcus pyogenes. Streptococcus pyogenes produces exotoxin, which is associated with tissue necrosis. Although bactericidal antibiotic therapy is necessary for eradicating Streptococcus pyogenes, adjunctive clindamycin may decrease toxin production, which could limit the extent of tissue necrosis. That makes answer C correct. Vancomycin should be reserved for patients with Staphylococcus aureus infection, who have beta-lactam allergy because beta-lactam resistance is rare. That makes answer B incorrect. Moreover, synergistic antibiotic therapy with gentamicin isn't needed, given the effectiveness of gram-positive beta-lactams against Streptococcus pyogenes. That makes answer D incorrect. The role of IVIG in streptococcal necrotizing fasciitis is controversial. A small randomized placebo-controlled trial, RPCT stratified on the basis of need for surgery and clindamycin treatment showed no improvement in survival or reduction in the time to no further progression of necrotizing fasciitis or cellulitis in 21 patients with streptococcal toxic shock syndrome. As such, the guidelines do not recommend IVIG until additional studies are available. That makes answer A incorrect. Let's move to the next question, please. And the next question reads, G.W.M. A 26-year-old female patient was recently diagnosed with an uncomplicated urinary tract infection at a urology clinic in town. 48 hours after initiating therapy with cotrimoxazole, she is admitted to USMLE ICU with severe systemic inflammatory response and a 30% total body surface area (TBSA) epidermolysis of her upper arms and back. 6 hours ago she presented to your accident and emergency department with only 10% TBSA involvement. New lesions since admission to the burn ICU include erythema of her thighs and oral cavity with TBSA now at 40%. Toxic epidermal necrolysis (TEN) is now suspected. Her SCORTEN score is 3. So, my question to you is, which of the options listed below would be the most appropriate initial pharmacotherapeutic intervention in G.W.M's case? Would it be A. high-dose systemic corticosteroids, or B. empiric vancomycin for wound prophylaxis, or C. cyclophosphamide, or would it be D. crystalloid resuscitation? I will give you 10 seconds to choose the correct answer from the options listed above. And the correct answer is D. crystalloid resuscitation. One of the cornerstones of managing severe cutaneous injury includes volume resuscitation, preferentially with crystalloids. That makes answer D correct. The usefulness of immunomodulating therapies such as corticosteroids and cyclophosphamide is limited by observational and poorly controlled evidence or case reports, thus the use of immunomodulating therapies should be reserved for specialty centers using formal protocols with consideration for treatment under clinical study or registry. That makes answers A and C incorrect. Wound care is imperative in these patients, however adding unnecessary drugs that could confound response or worsen the injury, e.g., antibiotics, should be avoided. That makes answer B incorrect unless there is an objectively suspected or confirmed infection. Let's move to the next question please. And the next question reads, G.W.M's condition deteriorates. The TBSA involvement is now 50%. There is worsening oral cavity involvement and progressing acute kidney injury. The ICU team considers IVIG as the next pharmacotherapeutic intervention. So my question to you is, which of the facts listed below best describes the evidence-based role of IVIG in managing TEN? Is it A. meta-analyses of the available evidence support that IVIG is standard of care in managing TEN, or B. multi-center pivotal trials show that IVIG is most efficacious for patients with ocular involvement, or C. IVIG should be reserved for specialty centers with interdisciplinary consensus protocols to guide use, or is it D. IVIG should be administered before the patient's condition progresses to TEN? I will give you 10 seconds to choose the correct answer from the options listed here. And the correct answer is C. IVIG should be reserved for specialty centers with interdisciplinary consensus protocols to guide use. Use of IVIG for Stevens-Johnson syndrome (SJS) or TEN is controversial. Available evidence is from case reports series, observational cohort studies, or small, single-center randomized trials. That makes answer B incorrect. Because of bias, limited external validity, and mixed results or observations between publications, meta-analyses and consensus guidelines do not broadly endorse the use of IVIG. That makes answer A incorrect. The available data analyses that suggest that IVIG decreases the SCORTEN-related mortality in patients with TEN and a middle to higher SCORTEN score, and there are even fewer data for the role of IVIG in SJS. That makes answer D incorrect. Given the limited evidence supporting pharmacotherapeutic interventions and the life-threatening severity of TEN, burn referral centers should base the decision to use IVIG on local protocols or guidelines developed by interdisciplinary practitioners who have objectively evaluated the available evidence regarding safety, efficacy and pharmacogenomics implications. That makes answer C correct. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 145.